I think this is the time now to start the examination of the pericardium of the patient. And like any part of the body, we have to start by inspection. And inspection here, not only for the pericardium, but for the chest. And we have to find if the chest shape of this patient is normal or abnormal. If it is abnormal, it may involve increased anteroposterior diameter, barrel-shaped chest, or pectus excavatum, or pectus craniatum, or pericardial bulge. So again, shape of chest may be normal, or barrel-shaped chest like in emphysema and COPD. It may be associated with increased anteroposterior diameter again in emphysema, and patient may have pectus excavatum or pectus craniatum. And after this, we have to concentrate on the pericardial area, and the best place to decide upon the pericardial area, if it is bulging or not, again in the middle line here, to compare the two sides. If it is bulging, it will be very clear, but if you go there, it might be confusing to decide accurately if it is bulging or not. And the pericardial bulge does indicate that there is cardiomegaly, and does indicate that this cardiomegaly is due to long-standing cardiac problem. Acute cardiac problem doesn't change the shape of the chest, particularly in adults and elderly age group. In youngs, the pericardial bulge is more common because the ossification of the bone is not yet taking place, and there is a lot of chondral junction, and it might be deformed under the effect of cardiomegaly. Not only this, but we have to look if there is mid-sternotomy scar of previous open heart surgery or not. We have to look at this place if there is a scar of the previous open heart surgery or not. Sometimes some cardiac surgery, what's called closed heart surgery, like closing patent ductus arteriosus and closed mitral valvotomy, may be done with left or right intercostal approach. So you may find left intercostal scar or right intercostal scar. So presence of intercostal scar or mid-sternotomy scar might indicate previous heart surgery. Not only this, but you may look at a scar in, if there is a scar or not in the infraclavicular region in the right and left. Right infraclavicular region and left. More and more in the left side. And this scar might be related to implantation of permanent pacemaker or implantable cardioverter defibrillator device. We call it ICD, implantable cardioverter defibrillator device. Usually it is implanted in the left infraclavicular fossa here. So you can see the scar, and you can see a little bulge due to the device itself, the battery or the generator of the device. After that, we have to look at the apex of the heart, at the apical impulse by inspection. We need good daylight for that. And we have to look in this way to see if I can see the apical impulse or not. We expect the apical impulse to be in the 5th or 4th left intercostal space in the mid-clavicular line in normally positioned heart and normal size heart. So we concentrate in this area to find if there is apical impulse or not. I can see the apical impulse in this place. So this place is just below the left nipple. It is in normal position. It's not displaced by rough inspection. But we'll verify its real position once we start palpation. Once we start palpation, we'll verify its real position. After inspecting the apical impulse, we have to inspect other precordial area for other pulsation on the left sternal border, in the pulmonary artery area, and on the pulmonary and on the aortic area, right, just right to the left, to the sternal border, right to sternal border in the second right intercostal space. And the pulmonary area is just left to the sternal border in the second left intercostal space. Again, apical impulse and its rough position. Then left sternal border if there is any pulsation, pulmonary area if there is any pulsation, aortic area if there is any pulsation. Then we look at the epigastric of the patient to see if there is any epigastric pulsation or not. I can't see any epigastric pulsation. I can't see any left parasternal pulsation. I can't see any pulmonary pulsation. I can't see any aortic pulsation. So this is the inspection of the pericardium and the inspection of the heart. What about palpation? Where do we start palpation? We start palpation by palpating the apical impulse. So in the site of inspection of apical impulse, and even if I don't inspect, if it is invisible, I put the palm of my hand just below the nipple of the patient or around the fourth and fifth left intercostal space until I feel the apical impulse. And in the majority of patients, I will feel it, particularly in patients with normal body habitus. But in obese individual and in patient with emphysema, I may not feel it. And if the heart is dextrocardic heart, if the heart is transposed to the other side, I will not feel it. So there is causes for impalpable apical impulse. Where is the apical impulse here? Exactly in the same place in which I have inspected. It is in this point. After I feel it with the palm, then I try to locate it with the tip of my index finger to be able to count and to find where it is exactly found, its anatomical site or its anatomical position. So to find its anatomical position, could you please raise your head up? Okay, okay, very good. I will start by suprasternal notch, trying to feel the sternal angle in this way. This is the sternal angle. So I go to the left. This is the second rib. So the space between second rib and the third rib will be the second left intercostal space. So this is the second. Then I palpate the third rib. Below it, there will be the third space. Then from third space to fourth left intercostal space in which the apical impulse is lying, and this is normal position concerning the intercostal spaces. What about its position in the vertical lines? This is the clavicle and this is the mid-clavicular line. If I draw a imaginary line like this, it will come across this point, so the apical impulse is lying in absolutely normal position. It is in the fourth left intercostal space at the mid-clavicular line. If it is in the fifth, still it will be normal. So fourth and the fifth left intercostal space at mid-clavicular line or just inside it, this is the normal position of the apical impulse. If it lies outside this line, so it is displaced laterally. If it is displaced in the sixth space, it will be displaced downward. If it is displaced in the sixth space and lateral to mid-clavicular line, so we call it displaced laterally and downward. And displacement of apical impulse means that there is cardiomegaly. There is cardiomegaly. And cardiomegaly here is usually due to left ventricular dilatation, left ventricular enlargement, and not due to right ventricular enlargement. As we know, the apical impulse is made mainly by the apex of the left ventricle. So if the left ventricle is dilated, the apical impulse will be shifted outward, downward, or both. After finishing from detecting the site of the apical impulse, we have to feel it for its character. Again, we have to learn what is the normal character by examining normal patients or normal individual, to keep in mind what is the feeling of normal apical impulse. Any deviation from the normal, it will be abnormal, and we have several types of abnormal apical impulses. Like what? Like hyperdynamic diffuse apical impulse, which will be associated with dilated left ventricle in cases of aortic regurgitation and in cases of mitral regurgitation. The apical impulse will be displaced outward and downward, and it will be wide. Normally the apical impulse is located by the tip of the finger. If it exceeds 2.5 centimeters in diameter, we call it diffuse. And if your hand impression, your impression about it, that it comes strongly or it hits your hand strongly and disappears rapidly, this is what we call it hyperdynamic apical impulse. So if it is diffuse, displaced and hyperdynamic, we have to understand that we are dealing with dilated left ventricle because of volume overload, and volume overload can be created by several problems like aortic regurgitation, mitral regurgitation, anemia, thyrotoxicosis, and many other causes. So we have to keep in mind this character, the diffuse and the hyperdynamic. Suppose the left ventricle is ejecting the blood against resistance and the ejection phase is long, like in cases of aortic regurgitation, then the apical impulse will be longer or sustained, and strong and sustained, heaving and sustained. It takes longer time because of prolonged ejection phase. So this is a third character, which is sustained apical impulse. In cases of mitral stenosis, the S1 will be very loud, and if there is any cardiac sound becoming very loud, we can feel it by tactile sensation, i.e. by palpation. So if we feel that with the apical impulse there is sharp sound felt with the hand, sharp sound which is palpable with the palm of the hand, we call this type or this kind of apical impulse tapping apex beat. Tapping apex beat. Tapping apex beat means palpable S1, palpable first heart sound, and this does occur mainly in cases of mitral stenosis. So by this we have normal apical impulse, we have hyperdynamic and diffuse, we have sustained apical impulse, and we have palpable S1 or tapping apical impulse. Then we have to feel the apical impulse for a palpable thrill. Thrill means palpable murmur. So the thrill which can be palpable at the apical impulse is the systolic thrill due to mitral regurgitation or diastolic thrill due to mitral stenosis. So we will palpate the apical impulse for position, we will palpate the apical impulse for character, we will palpate the apical impulse for sounds, particularly S1, and we will palpate it for thrill, systolic in mitral regurgitation and diastolic in mitral stenosis. After we finish from the palpation of apical impulse, we have to palpate the left sternal border or the parasternal area by the palm of the hand like this, or by the border or the edge of the hand like this, or by the heel of the hand like this. Whatever you like. You have three methods to palpate the left parasternal area. I myself prefer the palm of the hand vertical like this, to feel if there is left parasternal heave or not. If something is lifting your hand up, and in that case, if you feel that sign, left parasternal heave, this may indicate right ventricular enlargement, right ventricular hypertrophy, and or left atrial enlargement, huge left atrium. And the two phenomena may occur in severe mitral valve disease like severe mitral stenosis and severe mitral regurgitation, the left parasternal heave. Remember, left parasternal heave. At the same time, while I'm trying to feel the left parasternal heave, I have to appreciate if there is palpable sounds or thrills or not in the left parasternal area. For example, if we have a patient with ventricular septal defect, I may appreciate a systolic thrill on the third or fourth left intercostal space, just parasternal. So it is very important type of palpation. After we finish from the left parasternal palpation, we have to palpate the pulmonary area, and as I mentioned, this is the sternal angle, and this is the pulmonary area just in the second left intercostal space lateral to the sternum. So I fit my metacarbophalangeal joints, this eminence, I fit it into the second left intercostal space like this. And I try to feel pulsation, thrills, and sound. And the sound which may be felt here or palpable here is the pulmonary component of the second heart sound. So if that sound is appreciated or is felt or is palpable, this will indicate pulmonary hypertension. So in pulmonary area, I repeat, we have to palpate it for pulsation, which may be due to dilated pulmonary artery. We have to palpate it for thrill, which may be due to pulmonary stenosis, pulmonary valve stenosis, and we have to palpate it for possibility of palpable P2, which is secondary to pulmonary hypertension. Then after I finish palpating the pulmonary area, I go to the other side, same space, second space, but right. Just right to the sternum to palpate the aortic area. And the objectives of palpating the aortic area is aortic dilatation, aortic aneurysm, if it is pulsatile here, and if there is palpable aortic component, and if there is thrill due to aortic valve stenosis. So it is very important to palpate both pulmonary area and aortic area. Suppose by inspection we have found epigastric pulsation. Do we palpate it? Of course, we have to palpate it to find from where it is coming. And as you know, we have three sources for epigastric pulsation. If there is epigastric pulsation here, I just push my thumb parallel to the sternal, parallel to the costal margin like this. And I try to feel if the pulsation is coming from upward. This means that it is coming from the heart. And when we know that the most anterior chamber of the heart is right ventricle, so this pulsation will be coming from right ventricular enlargement if it is hitting the border of my thumb in this direction. But if the pulsations are coming from the liver, so they will be coming very easily when we palpate the liver like this. If we are palpating the liver and we find it pulsatile like this, so the origin of epigastric pulsation will be the left lobe of the liver. Suppose still there is epigastric pulsation and not coming from the heart and not coming from the ventricle, then we palpate in the middle line with the tips of the finger like this, gently, to see if it is coming from the back of the patient. This means that it is coming from the aorta. And this is common if the patient has abdominal aortic aneurysm, and if the patient is very lean with a scaphoid abdomen, or in children, you can palpate normal aorta when you push your fingers in the middle line like this. But in normal individual, if you palpate it easily, it might indicate presence of abdominal aortic aneurysm in the middle line. By this, we finished the palpation of the heart. Then we move to the auscultation, and this will be the final step in the pericardial examination. And before we start the auscultation, we have to know the parts of the stethoscope and how to use the stethoscope. The stethoscope is formed from a diaphragm, which is good in auscultating the high frequency sound. And there is another piece which is called the cone or the bell, which is good to appreciate low frequency sound. This cone will collect the low frequency sound, will be able to auscultate, and the diaphragm will make the appreciation and the auscultation of high frequency sound more easy than the bell. So we have to know when we can use the bell and when we can use the diaphragm. Let me start by the bell because its use is limited. We use the bell in the auscultation of S3 and S4 and the mid-diastolic rumbling murmur. Remember that, mid-diastolic rumbling murmur in cases of mitral stenosis and in cases of tricuspid stenosis. So the use of the pill is very limited. Only for S3 and S4. S3 and S4 usually they have low frequency sounds, low frequency vibrations, and it's the same for rumbling murmur of mitral stenosis and tricuspid stenosis. Mitral stenosis will be appreciated in mitral area and tricuspid stenosis in tricuspid area. This is an introduction to auscultation. And another point in the introduction, we have to know what are the auscultatory area when we deal with heart auscultation or cardiac auscultation. We have 5 auscultatory areas. And let me make marks on these 5 auscultatory areas. I appreciated the apical impulse here by palpation and by inspection. This is the apical area or the mitral area. Medial to it, this is in the fourth. So medial to it in the fourth, left intercostal space, just at the sternal border, this will be the tricuspid area in the fourth. In the third left intercostal space, there will be the second aortic area. In the second left intercostal space, just lateral to the sternum, this will be the pulmonary area. In the second right intercostal space, just lateral to sternal border, this will be first aortic area. So we have 5 auscultatory areas. First aortic area, second aortic area, pulmonary area, second aortic area, tricuspid area, and mitral area. Knowing this, we'll proceed with cardiac auscultation and we'll concentrate first on heart sounds. We have to appreciate first and second heart sound first. And we appreciate the first heart sound in the mitral area, much better than tricuspid area. By putting the diaphragm of a stethoscope, because S1 or first heart sound is high frequency sound, and we try to listen. Of course, we'll appreciate both the first and the second, but first will be louder in the mitral area. So we have to concentrate on the lub. Lub is the first heart sound and dub is the second heart sound. Then, if we want to concentrate on the second heart sound, we'll go to the pulmonary area, better than aortic area. Both of the components of the second heart sound are more appreciable on pulmonary area, but the aortic component alone is more appreciable at the aortic area. So pulmonary area is preferable to appreciate the proper second heart sound than aortic area. But in some cases in which we don't know exactly which component is more loud, we may compare the pulmonary area with the aortic area. If the second heart sound is louder in the aortic area, roughly speaking, the aortic component is louder than the pulmonary component. But in pulmonary area, if the second heart sound is louder than aortic area, this means that the pulmonary component is louder than the aortic component. So this is the importance of comparing the two areas for the second heart sound. This is a rough estimate and not a very accurate way to differentiate between the pulmonary heart sound, pulmonary component of second heart sound and aortic component. So once again, we appreciate better the first heart sound on mitral area and second heart sound on the pulmonary area. What is after that? We have to find if there is additional heart sound like S3 and S4, and this is accurately done by the bell of the stethoscope only on mitral and tricuspid. It has nothing to do with the base, because S3 and S4 are related to the left ventricle and right ventricle. So S3 and S4 should be appreciated in the diastolic phase in mitral area and in diastolic phase on tricuspid area. There is one remaining point how can you say that this is first and this is second heart sound? When I put my stethoscope here on mitral area and I want to know what is the first heart sound, that sound will be correlated with the beginning of carotid artery upstroke. I have to make what is called timing. I feel the carotid artery with the thumb as I indicated before like this, and the first heart sound will be correlated with the beginning of carotid upstroke. Second heart sound will be correlated with the down slope of the carotid upstroke, when the carotid upstroke is coming down. Exactly with the diacritic notch if we remember the carotid artery pressure curve. If we come here for the second heart sound, it is very easy again to correlate. And this timing is very, very important in differentiating between systolic and diastolic murmurs, early systolic and late systolic, early diastolic and late diastolic. All of this needs timing with the carotid artery impulse. So timing is very, very important in cardiac auscultation. After we finished from the heart sounds or appreciation of the heart sounds, we have to move to appreciate the murmurs if there is murmur. And as we know, roughly speaking, there is three kinds of murmur, not two, three kinds of murmur: systolic murmur, diastolic murmur, and continuous murmur. This is the main three kinds. And under systolic murmur, we may appreciate several types of systolic murmurs, like pan-systolic murmur in cases of mitral regurgitation. This is in chronic mitral regurgitation. Early systolic murmur in cases of acute mitral regurgitation. And ejection systolic murmur in cases of aortic stenosis and pulmonary stenosis. If we come to diastolic murmur may be early diastolic murmur in cases of aortic regurgitation. It may be mid to late systolic murmur, mid to late diastolic murmur, like in cases of mitral stenosis. We call it long mid-diastolic murmur with pre-systolic accentuation. And in systolic murmur also, we have another kind which is called mid to late systolic murmur in cases of mitral valve prolapse. So in every kind in systolic murmur, we have early systolic, we have mid to late systolic, we have pan-systolic murmur, we have ejection systolic murmur. Again, early systolic murmur in cases of acute mitral regurgitation, pan-systolic murmur in chronic mitral regurgitation, ejection systolic murmur in pulmonary stenosis and aortic stenosis, and diastolic murmur are subdivided to early diastolic murmur like in aortic regurgitation and pulmonary regurgitation, mid-diastolic murmur in mitral stenosis. Mid-diastolic murmur may be associated with perisystolic accentuation in mitral stenosis and tricuspid stenosis. The remaining type is the continuous murmur, and this does occur in cases of persistent ductus arteriosus, and we'll find it infraclavicular in this area due to patent ductus arteriosus. It will be pan-systolic and early diastolic, so it gives you the machinery type of sound, as if there is a train moving and you are hearing the sound of the train, machinery type of murmur. So it is appreciated in cases of patent or persistent ductus arteriosus in the left infraclavicular area. To appreciate these murmurs well and good, both systolic and diastolic, or even the machinery murmur, you need timing with carotid artery. So your thumb again is in carotid artery, and you start an area by an area, and you will call this method, if you go all through the 5 areas, by inching method. Let us start by mitral area, and we use the diaphragm to find if there is early systolic murmur or pan-systolic murmur. Then before I leave the mitral area, we have to use the bell to try to appreciate any mid-diastolic rumbling murmur due to mitral stenosis. Then the bell on tricuspid area to appreciate any mid-diastolic rumble due to tricuspid stenosis. Then the diaphragm to appreciate if there is pan-systolic murmur due to tricuspid regurgitation, Then I move the diaphragm to the third intercostal space. This is the fourth and the third, in which I may appreciate pan-systolic murmur due to ventricular septal defect. Then to the pulmonary area to find if there is ejection systolic murmur due to pulmonic stenosis or not, or early diastolic murmur due to pulmonic regurgitation. In the third left intercostal space here, also we may appreciate an early diastolic murmur due to aortic regurgitation. Then after the pulmonary area, I go to the first aortic area to trying to appreciate if there is ejection systolic murmur due to aortic stenosis and if there is early diastolic murmur due to aortic regurgitation. So look here, roughly speaking, the distance between every area and the other is about 1 inch in average body habitus. So we call this the inching method. The importance of this inching method that you are avoiding or trying to avoid any missing an auscultatory area and missing and a strong evidence of any cardiac lesion. So mitral area, then tricuspid area, then second aortic area, pulmonary area, and first aortic area. Inch by inch, not to miss, and in very systematic manner to avoid any missing. So this is the way. And all the time remember the golden rule, which is the timing to know if this is systolic or not, systolic or diastolic event, systolic or diastolic murmur, and if this early systolic or pan-systolic or mid to late systolic, and I give examples for all of these. I want just to repeat. Mitral regurgitation will be associated with pan-systolic murmur best here on the mitral area. And the maneuver which is used to magnify mitral regurgitation murmur is hand grip. Ask the patient to close his fist like this. This will increase the peripheral resistance and it will increase the leakage from left ventricle to left atrium and increase the amplitude of the murmur. Mitral regurgitation murmur propagates selectively to the axilla and to the back of the patient if it is severe. If we come to mitral stenosis murmur, which is associated with an opening snap and mid-diastolic rumble, and an opening snap here is a sharp sound, well appreciated with the diaphragm because it is high frequency sound, and it starts after the second heart sound, followed by the mid-diastolic rumble. We'll appreciate the opening snap with the diaphragm, but the mid-diastolic rumble with the bell. And the maneuvers which are used in cases of mild mitral stenosis is to turn the patient to left lateral. Please go to the left lateral decubitus this way and try to listen to the sound again or to the murmur with the bell. You will find that the magnitude of the murmur is increasing in left lateral. If you fail with this, then you may ask the patient to exercise for a while, few sitting up and lying down, sitting up and lying down in bed, and take him to the left lateral. This will give you the best situation to auscultate mid-diastolic rumble due to mitral stenosis. Then, if we come to tricuspid regurgitation murmur, which is pan-systolic murmur best heard on the tricuspid area, fourth and fifth left intercostal space at the sternal border, we ask the patient to take deep inspiration. And by deep inspiration, the venous return is increasing to the right side of the heart, and tricuspid regurgitation murmur will increase in amplitude. Then The ventricular septal defect murmur, which is pan-systolic murmur, is best heard on the third and fourth left intercostal space, and it is pan-systolic murmur. Again, the maneuver is hand grip. If you ask the patient to close his fist like this, the amplitude of the pan-systolic murmur due to VSD will increase, and its selective radiation will be to the right side of the chest, from the left to the right. Then the third left intercostal space represented the second aortic area, in which you may appreciate an early diastolic murmur due to aortic regurgitation. And early diastolic murmur due to aortic regurgitation increases in amplitude by the following maneuver. You ask the patient to sit up and lean forward, then you auscultate. The amplitude of the murmur will increase with sitting up. Could you please lean forward and this way? You are facilitating the backflow of the aortic regurgitation or the regurgitant jet from the aortic root to the left ventricle by this, and the amplitude of the murmur will increase. If you want to have another maneuver to help in appreciating very mild cases of aortic regurgitation, then you ask the patient while he is sitting up and leaning forward to do hand grip. Could you please close your fists? Without strain, without strain. So this is the way. So the maneuvers for aortic regurgitation are sitting up and leaning forward position, and you may ask the patient to do hand grip. Again, in the second aortic area, you may appreciate an ejection systolic murmur due to valvular or subvalvular aortic stenosis. Subvalvular aortic stenosis is like subaortic discrete membrane or HOCM, hypertrophic obstructive cardiomyopathy, or IHSS, which stands for idiopathic hypertrophic subaortic stenosis. The ejection systolic murmur of valvular aortic stenosis increases by expiration. Ask the patient to take in and to exhale out and hold. Then the murmur will increase on holding after exhalation. With exhalation and holding after exhalation, the amplitude of the murmur of aortic stenosis will increase. And this is very important maneuver. If this murmur is due to HOCM or IHSS, it will increase by Valsalva maneuver. You put your stethoscope and ask the patient to strain in. While he is straining, straining inside, the amplitude of the murmur will increase. Could you please? Okay. No, without your hand grip, just strain in. Without your hand grip, just strain in. Take deep, exhale, and then after that, strain. Strain, strain. As if you are defecating with difficulty. Strain. Okay. No. Don't take out and end. You know, you have to instruct your patient very well as if you are straining during defecation to pass the stool out. Okay? So good instruction to your patient is very important in performing any maneuver. You strain in, you do. This is the way. The murmur, the ejection systolic murmur due to HOCM will increase in the straining phases, first and second phase of Valsalva maneuver. And it will decrease again on the release phase. Once you release the strain, the murmur amplitude will decrease. The amplitude of the murmur will decrease. Then if we come to the pulmonary area, we have a possibility to appreciate ejection systolic murmur due to pulmonary valve stenosis. And this murmur will increase by deep inspiration. We ask the patient to take deep inspiration. The venous return will increase, and it will increase the amplitude of pulmonary stenosis. We put the stethoscope. Please take in. No, not strain. Just take, inhale. Inhale. Okay. While he is inhaling, inhale deeply. Okay. While he is taking good inspiration, deep inspiration, the murmur of pulmonic stenosis will increase. Same for pulmonic regurgitation. If patient is taking deep inspiration, the amplitude of the pulmonary regurgitation murmur, early diastolic murmur will increase. Then we move to the aortic area, and we have two possibilities. Either ejection systolic murmur, and again it will decrease by hand grip and increase by expiration. Could you please hand grip? So if there is ejection systolic murmur due to aortic stenosis, the amplitude will decrease by hand grip. Okay? You take in, get out, and hold. And hold. By this, you may increase the amplitude of ejection systolic murmur due to aortic stenosis. And again, we have to listen if there is early diastolic murmur to aortic regurgitation or not. And this early diastolic murmur will increase again by sitting up, leaning forward, and by hand grip. All of this will increase the amplitude of early diastolic murmur in the first and second aortic area. Just one point which should be mentioned about the ejection systolic murmur due to aortic stenosis, valvular aortic stenosis. It will be preceded by an additional high frequency sound which is called ejection click. Ejection click. So ejection click occurs after the first heart sound. It will be followed by a diamond-shaped murmur, crescendo decrescendo murmur. And that type of murmur, we call it ejection systolic murmur. In mild cases of aortic stenosis, that ejection systolic murmur will be short. In severe cases, it will be very long. It may occupy most of the systole. Back to the mitral area for another very important disease, which is mitral valve prolapse. What do we appreciate in mitral valve prolapse? We appreciate one or two clicks in early or mid systole, or sometimes late systole. And this click will be associated with some mid to late systolic murmur. And that is why we call it click murmur syndrome. And hand grip will help us in appreciating the clicks as well as the murmur on mitral area. And this is the proper description of mitral valve prolapse. S1 in mitral valve prolapse usually is normal, and there is non-ejection click with mid to late systolic murmur. In some cases of mitral valve prolapse, the systolic murmur will be hollow systolic murmur. In hollow systolic prolapse, it will be very similar to chronic mitral regurgitation murmur. So we have to remember that in some cases of mitral valve prolapse, the valve will be extremely damaged and the patient will have mitral regurgitation exactly like in cases of chronic mitral regurgitation due to rheumatic etiology. The remaining murmur is the continuous murmur, and as I mentioned, we have to appreciate that with the diaphragm in the infraclavicular region. And if we appreciate that machinery or continuous murmur, this will be a clue for the diagnosis of persistent ductus arteriosus. It's very important. By this, we have finished from the auscultation of the pericardium, and we may need to auscultate the back of the patient for few things. Could you please sit up? If we appreciate an ejection, if we appreciate an ejection systolic murmur on the pulmonary area, and we say that most likely this patient has pulmonary stenosis, pulmonary valve stenosis. This pulmonary stenosis may be associated with peripheral pulmonary artery stenosis, which may be appreciated on the back of the patient. So you may appreciate some ejection systolic murmur, particularly on the back of the patient, here and there. Second beneficial point of setting the patient up is you have to auscultate the lung basis for fine basal crepitation. And this is the way you ask the patient to take in and out. Could you please breathe in and out, deeply. Okay, bilaterally. Suppose you find that the patient is not dyspneic while he is lying down and there is some unilateral fine basal crepitation. So you have to ask him to cough out, please cough out, 1 or 2 times, cough. Okay. Once more. Then you listen again. Hypostatic crepitation may disappear after coughing out, but heart failure crepitation or crepitation due to left-sided heart failure will remain. The crepitation of left-side heart failure are fine crepitation, very similar to the sounds created by the friction of your hair. So just make friction of your hair above your ear and you'll hear some crepitation occurring due to that friction of the hair. And exactly this what occurs with heart failure, particularly mild cases of heart failure. In severe cases of heart failure, if the patient has pulmonary edema, then the crepitation will be coarse and it will be going upward, medium size and coarse. You have to screen it in the 2 sides. You have to compare the 2 sides. It may be going up to the upper zones. So it is very important to differentiate between mild cases of left side heart failure and severe pulmonary edema. In severe pulmonary edema, you will appreciate crackles all through lung fields anteriorly and posteriorly. Second point, when we examine the back of the patient in relation to cardiovascular system, we have to look at the sacrum. If the patient is bedridden and he has lower limb edema, it will accumulate around the sacral region, and we have to inspect and palpate it. We have to do the Bitting test to see if it is Bitting or not. Here, there is no Bitting edema. So it is very important to examine the pre-sacral region for sacral edema or perisacral edema, which may be related to right-sided heart failure. Then we ask the patient to lie down again. And from the inspection and palpation of epigastrium, we have to make some conclusion if this patient has, roughly speaking, hepatomegaly or not. If there is epigastric pulsation and if there is increased jugular venous pressure, then we are obliged to examine or to palpate the liver of the patient. And as you know from the previous talk of Dr. Ibrahim Saeed, that the best palpation of the liver starts in the right iliac fossa, and we ask the patient to take deep breath in and out and try to correlate between your hand movement and the inspiration. While he is taking in, you push your hand down to be able to palpate the border of the liver. Could you please open your mouth, take in and out deeply. This is the way until you get the lower border of the liver. I can't get the lower border of the liver. Now I can get it here just about 1 centimeter or half centimeter below the right costal margin, where in mid-clavicular line. So the line of palpation will be mid-clavicular line again. If the liver is not enlarged, I don't expect it to be pulsatile, because pulsatile means congested liver, and pulsatile because of the venous return or the tricuspid incompetence, which is pushing the blood again under the effect of high pressure in the right atrium, in the jugular veins and in the hepatic veins, causing the pulsation in the liver, which will be appreciable in cases of pulsatile hepatomegaly in this way, as I indicated before. So if there is hepatomegaly due to right-sided heart failure and tricuspid regurgitation, we expect that the liver will be tender and pulsatile. There will be pulsatile, tender hepatomegaly. But if the liver is not palpable below the right costal margin, like in this case, this is unlikely to have any sort of right-sided heart failure. Then, if we look at the abdomen, the contour of the abdomen of the patient like this, if the patient has pulsatile hepatomegaly and he has full abdomen, he has, big abdomen like this, we have to evaluate the patient if he has ascites or not. And from the previous lecture of Dr. Ibrahim Saeed or the previous how to examine of Dr. Ibrahim Said, how to percuss for shifting dullness, and how to percuss for fluid thrill in relation to ascites, which may be one of the signs of late stage right-sided heart failure. Then we come down to the lower limbs. We should not miss the lower limbs for two reasons. Lower limbs will tell us if there is lower limb edema and if the peripheral arteries are normal or not. We have to examine the lower limbs by inspection first. If there is any hair loss, if there is ulceration or not, if there is varicosity or not, varicose veins, which might be related to severe venous insufficiency in cases of right-sided heart failure. So if there is nothing of this, then we start to examine lower limb edema. And the preferable places in mild edema, we have to examine the medial part or medial region for the medial malleolus here, this place, because it is soft. So with the bulb of your thumb, you push it against the bone like this, and you try to see if it is bitten or not, or anterior to lateral malleolus in the dorsum of the foot like this. Again, there is no bitten edema. This is the ankle edema. If ankle edema is positive, is bitten, then we continue trying to find it in the leg, in the anterior shaft of the tibia or opposite to anterior shaft of the tibia like this. We keep steady pressure with the bulb of the finger, not the tip of the finger. We have to avoid our nails, and this is a bitten edema. Then we examine the other side to see if it is unilateral or bilateral. Bitten edema. It is bilateral, but it is more in the right leg than the left leg. Then we go higher, in higher place in the leg. Again, it is still there. And also here, but more in the right side. And we screen upward until no more bitten edema. And here, there is no more bitten edema. Here, there is no more bitten edema, means that the edema is confined to lower parts of the lower limbs, and in that case, it will be 2+ lower limb edema. If it is below knee, it will be 2+. If it is around ankle only, it will be 1+. If it is above knee, it will be 3+. If it appears in the scrotum and anterior abdominal wall, by benching the anterior abdominal wall like this, if we see it bitten, so it will be 4+ edema. So around the ankle again is 1+. In the legs below the knee, it is 2+. Above the knee joints, it is 3+. In the anterior abdominal wall and the scrotum, it will be 4+. What about this patient? This patient most likely has more edema in the right leg than the left leg. Let us look at the color of the two legs, if there is any difference or not. I can see that this patient has darker color in the right leg more than the left leg, a bit darker color. And this dark color may indicate a problem with his veins. He may have some deep varicosities and is causing some more venous stasis in this leg. So it is very important to look at the skin color, the hair distribution, if there is any ulceration or not, if there is any varicosity or not, and you have to evaluate the edema if it is bilateral or unilateral. Bilateral may be due to venous insufficiency in the two limbs. If it is unilateral, it may be due to venous insufficiency in one limb, due to more vasculosity in this one, or due to deep venous thrombosis. So this patient has to be investigated for this possibility. Then, after we finish the chrome evaluation of edema, we have to evaluate the peripheral arteries, and we start with dorsalis pedis. Dorsalis pedis artery is found in the dorsum of the foot just between the first and second metatarsal bones here, and I can feel it very nicely here. So once it is present with good volume, means that the circulation in that leg is well and good, and I don't need to palpate any more arteries. If it is absent, I will see the other side. I will palpate the other side in the same place. If it is present, well and good. If it is absent, then I will move to the posterior tibial artery behind the medial malleolus in the two sides. And in the other side, if it is absent here, then I go to the medial popliteal artery. I ask the patient to remove his trouser, and I feel the medial popliteal artery. I ask the patient to relax his leg on my arm like this, and I feel the medial popliteal artery in both sides. If it is absent in one side, I will go to the femoral artery in this side. If it is absent on two sides, then I will go to the femoral arteries in both sides. This is how to screen the peripheral arteries and the peripheral artery disease. We start by dorsalis pedis. If they are present, no need, no further action. If they are absent in the two sides or one side, we move to the posterior tibial of that side or in both sides. If it is bilaterally absent, and we screen one by one till the femoral artery pulsation. And as I mentioned before, the femoral artery pulsation is found in the junction between the outer 2/3 of the inguinal ligament and the medial third of that ligament. And by this, we'll be able to say that we finished the cardiovascular system examination of this gentleman. Thank you very much.